and I probably should change it, but whatever. This is what we're going to cover today. So we'll talk about our primary survey, which is our, stop any bleeding if you see it, and then our airway, breathing, circulation, disability, exposed, the patient, and then our fast, and then if they can go to CT scan, if they're stable, we'll send them there. And here's our warm-up case. We got a 45-year-old male, unrestrained passenger in a motor vehicle accident. Vehicle versus pole. He was ejected. He's intoxicated but alert, talking, and belligerent. EMS brings the patient in with C-spine precautions, if I can talk this morning. And on the backboard, vitals 105, heart rate 95 or 65, blood pressure. No medical complaints, but on the exam, he's got evidence of head trauma, multiple facial accidents. I don't even know how he survived if he was ejected. Most ejections from a vehicle is not good. But he's made it this far, so we'll talk about what we go through today, and that's going to be our ABCs that we kind of just covered: stabilize, treat any life-threatening injuries, and then if the big thing for us is, do they need to go from the trauma room to the operating room, or is this somebody we can manage and dispo in the ED, or do they need to be admitted to the hospital and monitored for the next 24 hours? And we'll get into when and why we do that. But it's pretty common ED complaint. You guys will see minor traumas like, usually lower acuity motor vehicle collisions without much damage. And a lot of that will be determined by EMS as they bring those patients in. But trauma is, one of the leading cause of death in younger patients. So usually we say 45 and less. And then it's going to be about, nearly half of the deaths in that age group. It's usually worse for elderly or older patients when they're involved in trauma. And then it's not just the initial trauma that we have a problem with. It's going to be like the sequela from the trauma if they survive it down the road. All right, so we got we talk about trauma, we got like a trimodal distribution of death. So, probably, I want to say it's more than half the patients, I can't remember the exact number. They die on the scene. So, and that's usually from either massive head injury or some sort of massive vascular chest injury. So like a ruptured aorta, those things are, they are not very survivable. So that's kind of the first peak we see of these deaths. And then the next one's going to be where we come in from our, the EMS side of the house, and that's somebody we can potentially fix if we can get to them in the first hour or two. And then you have like your later distribution of death for those patients, like sepsis, like multi-organ dysfunction and things like that, infection once they're hospitalized, or brain injury is going to be a big one that we see as well. And that's usually like a week to 2 weeks down the line, or kind of our death distributions from trauma. So they came up with it, they passed like a Trauma Care Systems Act, basically so we can designate certain levels of trauma. So that's why we have our level 1 trauma centers versus level 2 versus level 3. A lot of the facilities we have in the military are going to be like level 3 at most of the places we work. I don't know what Hood is. I know I don't know what Bragg is. I know Hood's like a level 3 trauma center, which means, we don't have the same capabilities as a level 1, which is going to be our, basically our specialty services. So that'll be like our neurosurge. You got to have neurosurgical capabilities, ICU capabilities, like trauma ICU capabilities. Spine surgeons and everybody else has to be there 24/7, which is what kind of differentiates our level 1 trauma center. And here's some other criteria. So you got to meet a certain amount of volume, so 1,200 patients or 240 admissions. And then they can all, they have to have an ISS of usually over 15, which is just a score we come up with, depending on whether there's head and neck trauma, face trauma, chest, abdomen, pelvis, extremities, anything like that. They also have to have surgical capabilities. They have to conduct trauma research. And then all of our level 1s are going to be teaching hospitals as well. So they'll have some sort of residence there, and they'll be a leader in education. And that's what really designates our level 1 trauma centers. Here in San Antonio, we got a couple of them. So we have we have BAMC, and then we have University Hospital. And I don't remember if Methodist, I know they were trying to become a level 1. I don't think they have, but maybe they have. But yeah, we have 2 here in San Antonio. So like the EMS, or we call it MedCom, they kind of direct where those patients go depending on volume or what basically they delivered to them before. So there's like a triage system in place and what they can handle. They look at bed capabilities as well. Sometimes all the beds are full. They may have to divert to another facility. But for all these patients, we do like a multidisciplinary evaluation, which is our primary, secondary survey, maybe a tertiary survey. If the patient's stable enough, that normally happens after the operating room and on the ICU. But the important thing is that we have a trauma team on standby 24 hours a day, 7 days a week. And they're able to take these patients straight to the operating room, which is what normally happens at a trauma center. And I say normally, I want to say like probably, but what percentage do you guys think goes to the operating room that comes to a trauma center? So I think they say it's like 40. I think it's like 10, like you say. I think it's like 10%. But you know, like, so not everybody goes to the operating room that shows up to a trauma center. A lot of patients are able to be downgraded or dispositioned from the emergency department. And when we think about trauma, we think about like all this cool, sexy stuff, like people getting shot, stabbed, motor vehicle accidents. Well, half the trauma patients are actually elderly patients that fall from standing, which is what they don't tell you, so it's not as cool. And they do have significant injuries, so you got a lot of brain bleeds, a lot of fractures, things like that. You know, hip fractures are a big one. Those elderly patients that fall. So that's actually a lot of what we see at a trauma center, oddly enough, especially at BAMC. I don't know if they purposely divert all the elderly patients there, but I feel like they do. And I've worked at both of them, so you know, I've had experience at both sites. All right, so you know, the well-functioning system. You know, we have an EMS system that's set up here in well, Bexar County is technically, I think, what they consider it here. And they kind of decide, you know, different areas and pockets that they have coverage for, and then they call. And that EMS initially will send whether they think it's going to be like a vehicle that requires a higher level of care versus just minor level, like BLS type care. So there are different ambulances and different capabilities. Really, it's the providers and what equipment they have with them. And then we have our pre-hospital and then our hospital phase. So the pre-hospital focus is all those big things. So any massive bleeding, they need to stop. I think here in Bexar County, we actually give whole blood in our ambulances now. And we have for a few years. So that's going to be like county dependent and whether they have the appropriate medical director or medical control so they can actually perform those kind of interventions. But a lot of the bigger cities are going to have, you know, be able to push blood in their ambulances as well to get them there. And then we want to, you know, control their airways, C-spine control, respiration, circulation, hypothermia prevention. Has everybody learned the March algorithm from like TC3 and all that? Hopefully. Everybody's supposed to go through TC3, right? No? Yeah, they are. Sorry. In the Army, they are anyway. It's like a 10-level skill. All right, so here's kind of our trauma system entry criteria. So we have certain criteria that requires them to go to a level 1 trauma center versus level 2 versus level 3. These are kind of rough guidelines. So any trauma with like hypotension, they got a GCS that might require some sort of neurosurgical intervention. They'll likely go to a level 1 trauma center. We also look at like injury patterns. So any like head, like penetrating head injury is going to be a big one, or neck, or anything involving those large vessels like your aorta. Anything really in the chest is probably going to go to a level 1 trauma center. They look at mechanism too, so depending on, you know, it's kind of hard to, I guess probably not hard since EMS does it all the time, but they look at how bad the intrusion is for the motor vehicle accident. They like to show you pictures of it. And sometimes they'll, like a lot of times when they come to like a level 3, because I was at Fort Hood as the assistant program director there for the Emergency Medicine Fellowship, they'd always show me pictures of the vehicle, and I'm like, you guys probably should have went to a real trauma center. How bad that is. But sometimes patients are perfectly fine and their vehicle is just like crushed to nothing, and you're like, holy cow. Any injection should probably go to a level 1 trauma center, or they definitely should. Motorcycles, usually always a bad outcome. Anybody drive a motorcycle in here? You should probably stop, or ride one. Yeah, you should probably stop. Yeah, that's true. So yeah, these are like rough criteria, like fall from 20 feet seems high to me. That's one of the criteria. I don't know. I feel like, yeah, that just seems a little high to me. 2 stories. I don't know about that, but these are certain ones that have to go, are supposed to go to our level 1 trauma centers. And then EMS should call the hospital and provide some sort of missed report. And that's kind of the same thing that we use, or it is the same thing we use, it's like NATO standard. So we use it like downrange when we're deployed as well. And really, we just want to know the mechanism of the trauma, what sort of injuries, and then what signs and symptoms they have, and what treatments have they done so far. So this will normally look like, there was a motor vehicle collision, they've got a fractured femur, bleeding is controlled and minimal. We put them in a splint, and we've started 2 large bore IVs. Is kind of how the missed report goes when they call it up to us. Sometimes it's very vague, but they try to give us as much as they can so we can be prepared with the amount of personnel or whatever's required for the trauma. And normally we'll have that identified beforehand, which we'll talk about in a second, like identifying our team is going to be one of our initial steps. If we can get this information in the pre-hospital phase, it can be important. So one of the issues like with EMS or with the patients that present is a lot of times they're obtunded. When they come by ambulance, they don't have any family with them. So we don't know a lot about their past medical history, which is unfortunate. We don't know a lot of times if they're on blood thinners or anything like that. So sometimes we assume they are. But these are big things we want to know. Like why do we want to know beta blockers if they have it?
Could mask.
Yeah, it could mask like a tachycardia, right? So, they may not, their body may not, their physiological response may not be the same as somebody who's not on a beta blocker. Yeah, and then if we know that they're intoxicated, that's always great. But a lot of times there'll be some intoxicated, we don't know what's going on with them. All right, so prior to arrival, this is going to be one of our most important steps. And then at a trauma center, and even any level, you guys will deal with this in. Hopefully deal with it in phase 2. You'll be part of one of these teams. And usually at the beginning of every shift in the ER, we identify who's the team leader. And then the team leader is going to say, hey, you're going to be the right side of the bed. You're going to be the left side of the bed. You're going to be airway. Your nurses or medics are going to be starting your IVs. You're going to have somebody push your medications. And then somebody, documenting, which is always important. And something, that tends to be done afterwards. All right. And then if they're brought to the wrong EDs, we have to consider transfer, but we have to stabilize them first. So that really doesn't matter. We still have to go through our primary survey, secondary survey, and everything there. But for all our trauma, we start with our initial assessment. And then we do our primary survey, and then followed by our secondary survey if they're stable enough, or they might just go straight to the operating room. But our goal for the primary survey, and the reason we do it this specific way, is because they've done studies that if we actually have an organized algorithmic fashion when we're treating trauma, it's shown to improve mortality and morbidity. So it is helpful. Some people say trauma is boring because it's kind of algorithm based, which it is, but it's still pretty stressful trying to find all those crazy injuries and everything else they have. But here's what it looks like. So you get a team leader usually at the foot of the bed directing traffic and directing treatment. And then you have, when it says like exam 1, exam 2, and airway are usually the 3 physicians, or it'll be a PA, or it'll be a resident on there. You guys might do it as a student. or you may be just assisting them with it, depending on how proficient you guys are. So you have your airway person is normally clavicles up, so they're gonna, first thing they're gonna assess is the airway. They're gonna evaluate for any like neck or facial injuries associated with it. They'll intubate if they need to. The right and left side of the bed are both clavicles down, so they're gonna evaluate everything from the clavicles down, so all the extremities, and then they just take the right side of the bed or the left side of the bed, so whoever's on it does that side of the body. And then you have your nurses on there who are going to be hooking them up to the monitor, getting large bore IV access, preferably 2. And then you'll have some sort of scribe. One of them will be, one of the nurses will be designated to push the medications or grab any medications we need, and then RT should be present, so your respiratory therapist should be there as well to help you with your ventilator and all your ventilator settings. And one of the like important jobs is, you know, at the beginning of every shift, you guys are usually responsible, like usually students or somebody after they're trained is responsible for inventory and everything in the trauma room, making sure you have all the appropriate airway equipment. And there will be checklists and things like that. So it is, you know, it is like, you know, like how pilots use checklists, and it's supposed to be safer and less errors. We do the same thing in medicine. We'll have checklists there. So that we know we have the appropriate equipment and everything we need for when we have these traumas. And here's what it looks like. Complete chaos, what it normally looks like, honestly. It's kind of controlled chaos, I should say. So you usually have quite a bit of people there around the bed, and that's like the team leader perfect stance right there, just sitting there with their arms crossed, kind of watching everything. Once you have everybody trained and you're like a well-oiled machine, the team leader really doesn't do a lot other than make sure it's all happening. And the reason we do this, and it's easy because we do it the same way every time. We go through our primary surveys, so our ABC, you know, X, A, B, C, D, E, F, G, and then we either go to the OR or to the CT scanner at that point. And we'll dive into that in just a second and talk about it. Here's another, this looks like BAMC actually. So what's nice at a lot of the facilities, and even like level 3s, you'll have the monitors on the wall so everybody can see. You'll also have, like when you're intubating, we do video laryngoscopy now, so you'll be able to watch, everybody in the room is able to watch that tube go in the appropriate place. And they'll see the vocal cords, they'll see the tube pass through, so everybody, so even the team leader can say, I know we have a definitive airway, we're not in the esophagus, that was appropriate. There are some limitations to it, we'll talk about it during the next lecture. Which, if you can imagine, it's a video scope, so like any blood in that airway is going to kind of affect that. So we may have to transition to a direct laryngoscopy, which will hopefully make sense tomorrow during our airway lecture. If you don't know, video versus, we call it VL versus DL, video versus direct laryngoscopy. All right. So here's our primary survey, and this is what we do. Same way every time on all of our patients. And we do it in a sequential fashion. So that's how we need to look at it. We need to go through this in you know, our X, A, B, C, D, F, G, and anything we find along the way, we fix it before we move on to the next thing. So if there's massive bleeding, we need to stop that before we move on to airway. And this is how we teach it, right? But in, you know, a trauma center, everybody's doing it at the exact same time. But how you guys need to conceptualize it is we have to fix this before we move on. And that's how it'll be on a test question. So if they don't have an airway and, you know, you're on breathing and you see like unilateral chest rise and fall, but you haven't established an airway yet, you need to do the airway first and then move on to breathing is kind of how we look at this. But the first thing we do is stop any massive external bleeding. So not like minor bleeding, this is going to be things like a tourniquet, like, you know, severe extremity hemorrhage, adjunctional hemorrhage. So we're going to put a tourniquet on, we're going to use some sort of compressive dressing, or we might use some sort of like combat gauze or something that can help stop that bleeding before we move on to the next thing. And then first is airway, so we need to open their airway and assess it. We need to look for any facial trauma, so they may have like foreign bodies or teeth in that airway. So that's what the person at the airway is assessing. And they're evaluating for any sort of airway compromise and then intubating if need be. If they don't need to intubate, a lot of times we can use something very non-invasive, like a nasopharyngeal airway. Has anybody used those here before? Yeah? No? Well, we're going to practice with them. Like when I was trained, we usually put them in each other, so you stick the tube down everybody's nose. It's, you know, fun. We had to do it on ourselves even. It's not as bad as you'd think. It's like an initial pop, and you're like, oh, okay, that was pretty easy. So it's going to be like our most minimally invasive kind of procedures we're going to do at the airway. And sometimes we can put 2 of those in just in case we have to bag them later prior to securing a definitive airway. That's going to be kind of the measures we're using. If they don't have a C-collar on at this point, we're placing a C-collar on them if the mechanism is appropriate for a C-collar. So like motor vehicle accidents, falls, things like that, they're going to have C-collar on. And most of these patients should have already presented with a C-collar on, so EMS is usually pretty good about it. But every once in a while, we'll have to place one on them if they don't have it yet. And those are usually the more minor motor vehicle accidents, but they'll complain of neck pain, so we'll throw it on at the beginning during our airway. Next, we move on to breathing. So how's my chest? Do I have equal chest rise and fall? We're evaluating for any sort of penetrating injuries that we can see on the anterior side of the chest wall. And then what's our respiratory rate? Are they, you know, tachypnic? Next, we move on to circulation. So that's, checking their pulses in all 4 extremities, normally our radial pulses. And then our DP and PT pulses. Like, what is our, like, kind of estimated blood pressure if we have a radial pulse? Does anybody know? It's like 80 over palp or so, yeah. So if they have that, they have, you know, semi-decent blood pressure. Next, we're moving on to disability. So we do a brief neuro exam, and that's usually done, you know, by the airway person at the head of the bed. So they're establishing the GCS. And the nice thing is in the trauma rooms, we have a big GCS poster on the wall to help us out. We're looking for pupillary response. So are they equal? Do I have an equal pupillary response? Are they sluggish? Do I have, you know, what's one of them dilated? Looking for any signs of like head injury. And then we want to expose that patient if we haven't done so already. So we're undressing them, we're cutting everything off, especially in a trauma patient. And then we want to expose to see every inch of skin on that patient. So this is where we need to, you know, assess the posterior side of the patient as well. We usually do that at the end of our primary survey. So we'll expose the patient, evaluate the anterior portion of the body, and then we log roll them. When we log roll them, we need to check the entire spine. We need to look at the posterior thorax. We need to lift all their arms up because you can get, you know, penetrating injury can hide in that axillary area. So we want to evaluate all those, and then we want to check their entire spine. We check, we do a digital rectal exam as well, looking for any blood or, you know, neurologic deficits that we might find. When we log roll them, that's when we take them off the backboard if they're on one. So depending on the mechanism and they present with a backboard, we're going to remove the backboard. Even if they have an injury, we're still going to remove that backboard. And then we have EFAST on there at the end. It's like an adjunct to our primary survey. The 3 imaging we may get during the primary surveys are FAST, which we're definitely going to get. And then we get a chest x-ray, and we may or may not get a pelvic x-ray if we suspect some sort of pelvic injury. And once we complete that, if they're stable and they don't need to go to the OR, we'll likely do a CT scan on them. And if they're unstable, they go right to the OR. But we'll dive into it here. So our primary survey, so any sort of extremity hemorrhage, we're going to use our tourniquet. Even in trauma center, we're still using our tourniquet. And most of them are using CAT tourniquets nowadays too. So, at least all the ones I've worked at, we're using CAT tourniquets in the emergency department for stopping any extremity hemorrhage. For junctional wounds, we don't really use any of those like fancy junctional tourniquets or anything. We just kind of pack those wounds with some sort of hemostatic agent, like our combat gauze is going to be the one that we utilize nowadays. There were older ones that didn't work as well, but we don't really use those anymore. And then some sort of direct pressure. So you may be the guy that's just sitting there holding pressure sometimes until you can stabilize that bleed or finish your primary survey. All right, there's our airway management. So what it normally looks like, when the patient rolls in the room, the team leader's usually like, hey, what's your name? So if they can tell you their name, we're like, cool, they got an airway, great. And then if they can't, that's when we need to assess a little bit further and decide whether we need to secure that airway or whether they're protecting it on their own. If they can't talk, then we need to evaluate, do I need a definitive airway? And that's typically when we'll intubate that patient at that point. So during the airway assessment, we're looking for any sort of like foreign bodies in their teeth. They might have maxillofacial fractures, so a lot of times we're just palpating the midface for stability while we're doing this. And then we want to perform our jaw thrust maneuver. You guys probably haven't all taken BLS because that's usually at the end of the semester. But there's a couple different methods we can use to open that airway. So you have your jaw thrust, which is going to limit the amount of movement versus your head tilt chin lift. So if they have any sort of suspected C-spine injury, we're going to use that jaw thrust maneuver. Prior, like let's say they came in without a C-collar, so we're going to provide inline C-collar stabilization, our manual stabilization of the C-collar with our hands, and we normally place them at the shoulders with their head in between our forearms, just to limit any sort of movement until we get that C-collar on there. And it's usually, it's kind of an awkward thing because the person who's controlling the airway isn't the one doing it, so that'll probably be like one of your guys' jobs as a student, and you'll be like bent down at the airway person's crotch, and it's all awkward, and you're down there just holding manual stabilization until we get that airway or that C-collar on there. We also have to do the same thing if we're intubating them, and we take the C-collar off because we may need a little bit more movement because it can limit our visualization. So we'll also have somebody provide manual stabilization as well for that C-collar. All right, here's our nasopharyngeal airway. So this is like our least invasive, and then we'll move into our like more invasive, or what we like to call definitive airways. Some say invasive versus non-invasive, but so our nasopharyngeal airway goes in the nair. You just you're supposed to measure it first from your nair to the tragus of your ear for size, but we usually only have one or two sizes, and that's like really big or really small. So the large one works pretty well for most patients. They say it's about your pinky size is what can go in there. I guess that's what we can use to pick our nose or something. We have our oropharyngeal airway, which is appropriate. However, if a patient has a gag reflex, that one's less preferred. So we typically don't use it because if the patient that we need that in, we probably just need to intubate them because likely they have some sort of head injury or they're comatose in some fashion, and we're going to need to secure their airway. But an oropharyngeal airway is an option, and a lot of times they'll use it under anesthesia during surgery. So if you guys do anesthesia rotations, you'll see it used quite frequently. And like I said, you got to use two-person spinal stabilization technique. So really, one person's providing that manual spinal stabilization while the other is intubating the patient. If they vomit, we need to log roll them, make sure we have our suction ready so we can suction anything out of there. And that's usually the airway person's job. If you're in charge of the airway for it, you always want to check your suction beforehand. And you want to make sure you have a backup suction as well. So, one is none, two is one kind of situation. And this will all be part of your checklist prior to your shift, or after every trauma patient, you'll change all that out and make sure you have working suction beforehand. And then I think you guys already learned GCS 8 intubate, so any GCS 8 or less, we just need to secure their airway because they're, comatose in some sort of fashion. So like, probably from a head injury. I mean, it could be intoxication as well. But these are patients you're going to need to protect their airway, so we're going to intubate them. Yeah, that's our direct laryngoscopy. And as you can see, he's kind of on there with his, looking in the airway visually. So it kind of limits you to the person that's actually doing the intubation. They're the only one that can visualize it going through the vocal cords. And that's going to be your best method for determining whether you aren't in the esophagus. So you got to visualize it going through the vocal cords, which is why the video laryngoscopy is much better and is more preferred now. We have some for our lab, so you'll notice they have this weird hyperangulated blade. These are either you got one that's like kind of C-shaped, and the other one's a straight blade. And it takes a little bit of getting used to if you've done a lot of direct laryngoscopy, switching over to the video. But once you get the hang of the video, it's like a joystick. It's like hyperangulated, and you just kind of go in there and you're like moving around like a little joystick, and it actually works a lot better once you get used to it. You have a guy there with a bougie, so that white plastic tubing there is what we call a bougie. So sometimes we can put that through the vocal cords first, and then we can feed a tube over top of it. So that can be used for like more difficult airways, or some people prefer to use it all the time. So it'll be just kind of shooter's preference and what you're trained with and learn with. Has anybody used a bougie before? Yeah. So pretty common. You'll also have them like with your crikes as well. They'll come with a smaller bougie with it. All right. So we want to do, and we'll talk about it tomorrow, our difficult airway assessment. But things we need to consider, like if their neck is immobilized, it can make it a little bit more difficult. So when they're in the C-collar, it can be more difficult. Obese patients, it can be more difficult if there's blood or any vomitus in the airway. If they have, an unstable, like mid-face fracture can make it difficult. Any foreign bodies like teeth in there can make it very difficult. Or anything else, like especially with blast injuries, you'll sometimes find some weird stuff in the airway that surprises you. But like I said, video laryngoscopy is the way to go now, and that's what most places are training with. I would urge you guys, if you have rotations for anesthesians, and a lot of the sites will, but certain places might be oversaturated with learners. And that's one of the issues. Like, is anybody going to BAMC? Who's going to BAMC? Yeah, so BAMC is there's a lot of learners there. So it can be, you may not get as many intubations while you're there just because the amount of people training, but working with your anesthesia colleagues is helpful because they do direct laryngoscopy, they don't do video. And that's good to learn on because in the Army, we only have direct laryngoscopy at the roll ones. So it is good to practice and learn with those, which we'll practice during our lab too. And then you always want to have a backup, which if all else fails, we have our cricothyroidotomy. So that's when we're going to make an incision over that, cricothyroid membrane, and we're going to put a tube straight into the trachea. And if they have any like maxillofacial injuries that are concerning, or we can't stick a tube down them, like an endotracheal tube, that's when we would use our cric. So I always like to have my cric ready because I think it wards off like bad spirits, and if I have my cric, hopefully I don't have to use it. But you need to be trained and ready to use it if need be, which is not very hard once you learn it. All right, here's how our video laryngoscopy works. So the GlideScope is going to be a very common one. You guys are going to see, and that's what a lot of facilities will use. They'll use this, or another one's like called the CMAC, I think, is the other. Those are the two most common video laryngoscopy scopes you'll have. And you'll have a little monitor right in front of you that you're watching on, and then a lot of places will have it'll have screens on the wall that you can see it on as well. And you're really just using this light and a hyperangulated blade with a camera on the end of it. And you should get that great visualization of the vocal cords like in the picture there, and you want to watch your tube pass right through those. Here's some more portable video laryngoscopy scope. We have little portable glide scopes with little mini screens like this big. That's what we're training on. Same blades though, so it's the same kind of concept. Once you guys are at your phase 2 and if you're actually intubating in the emergency department of the trauma room. And there's just different brands, so get used to whichever brand you have and what size you guys most commonly need. All right, so we won't talk about Nexus much here, but there are, we'll talk about it later in the lectures. We'll talk about our Nexus criteria. So this is, anybody know, did you guys learn Nexus already? No? So this is basically a criteria we use to help clear that C collar on the patient, or help us kind of determine whether we think there's a C-spine injury, whether we need imaging or not is really what it's utilized for. So sometimes we can clear it during our secondary survey. So obviously the patient has to be, awake, alert, oriented, and we'll cover what that different criteria is. But it's pretty easy. Like, is there any midline tenderness? We also look at the mechanism. Are they intoxicated? What's their GCS? Things like that. And we'll go over those criteria during our neck trauma lectures. After we secure the airway, that's when we move on to breathing. So we have to make sure that's taken care of first. And in the trauma center, it's going to all be done at the same time. But, if you're out there by yourself or at a roll 1, this is kind of the algorithm you need to take, or if you don't have enough personnel. The other important thing is that you're training those medics how to appropriately perform the primary survey, whose job it is to do what. So that's why it's important you guys know this. And you can actually train them, because you don't want to be the one doing all this, I can assure you that. It's not fun. All right, after you get the airway, you need to assess their breathing. The first thing is just obviously a visual, your visual inspection. So do I see any penetrating injury? Do they have a deviated trachea? Do I see equal rise and fall of the chest? And then we want to listen to breath sounds as well. So during our breathing, we're evaluating, usually since they're laying down, typically we're just listening to our superior portion of the lungs, and then we're kind of checking here at the bases laterally. And if we have any sort of absence of breath sounds, we have unilateral chest rise and fall, then we're going to need to do some sort of intervention. So if we kind of remember back to the atraumatic pneumothorax type picture, if we suspect a tension pneumothorax, that's when we need to do a needle chest decompression on the patient, or needle thoracostomy. So we put a needle in there, or we can do a finger thoracostomy as well. But we need to perform some sort of intervention at this point if we suspect any tension physiology prior to moving on to our circulation. So immediate intervention needs to happen. All right, there's, nice picture. What are we seeing here? Yeah, this is like a right main stem innovation. So it can kind of look like a pneumothorax, or it can kind of trick you on what is causing this. I have an opacified hemithorax. And if you just intubated, this is something you need to consider in the patient. And you just got to move the tube back. But here are some of the interventions we can do. So if we have penetrating, or what we call a sucking chest wound, we want to put an occlusive dressing on there. And there's a lot of different kinds out there. So you have your H&H dressing, they have all these more advanced ones. I don't remember all the names of them, but it's something like that. That picture on there, that one's supposed to let air out of it. A lot of the ones we use don't have those little air valves on them. One of the keys is making sure you wipe that patient down first, because it's hard to put them over blood. And then if it's tension, we do that needle or finger, and then followed by a chest tube immediately. Sucking chest wound, put something on there to occlude it. And then if you right main stem them, pull the tube back. All right, moving on to circulation. So, if we haven't placed a tourniquet on there for massive hemorrhage yet, that's something we need to do. If it's a junctional area, we need to apply direct pressure to that patient, or if they're bleeding from anywhere, like in the thorax, we need to place some sort of dressing over that so we can try to limit the amount of bleeding that patient has. This is also when we're kind of assessing whether we think we need blood products on board or not. And for trauma, especially if they're bleeding, that's going to be our preferred agent we're going to use is blood on those patients. And a lot of times, you know, a lot of the bigger facilities, we switch to whole blood now. So, and we'll talk about it, I think, in the next few slides. We usually do like a 1-to-1-to-1 ratio blood, or PRBCs, plasma, and platelets. Well, we found whole blood does a balanced transfusion just as appropriately, and we don't have to unthaw all of those other products. So we've transitioned in a lot of places over to just fresh whole blood for those patients, just because it takes a while to unthaw all the other ones, sometimes up to 20 minutes. They don't last long once they're unthawed, so we've seen a transition to our whole blood. All right. So there are some of the things we're assessing, if you guys remember, like your shock chart and things like that. So we're looking at the heart rate, pulse pressure. We're looking at skin color. Are they still talking to me? What's their level of consciousness? And then peripheral pulses as well. So do I still have, strong radial pulses or absent radial pulses? So these are other indicators. We need to get some sort of blood or fluids on board in these patients. And then any hypotensive trauma patient, we assume it's hemorrhagic shock, which is why we're giving blood for these patients. And then, it is on a continuum. I think you guys tested on your surgery test, like the different classifications of shock. I'm not going to ask you those, but because we're not sitting there in the trauma room like, I think it's class 1 shock, 2, 3, 4. Really, if we suspect any sort of, bleeding and shock, we're going to start blood products immediately. And then other things, like I said earlier, like beta blockers can mask that tachycardia that your body typically has, which is usually one of the earlier signs you see in that hemorrhagic shock. So their body's trying to compensate, so they'll increase their cardiac output. And then here's our classification of shock. I'm not going to ask you classification of shock. But as you can kind of see on the continuum here, like your blood pressure starts to decrease as it gets further. But one of the things you see initially is going to be like that tachycardia. So that should usually kind of hone you in. And then the other thing is going to be like their mental status is a big one as well. So they start to get like anxious, agitated, and then they start to get kind of somnolent and tired. So that's one of the other factors we're looking at if we haven't taken their airway already, and trying to estimate their blood loss or their percentage of blood loss. But I think they say you can use like 30% sometimes of blood loss. You can, the body's still going to compensate appropriately depending on age and comorbidities of the patient. Every patient's going to get 2 large bore IVs initially. So during our primary survey, we're starting to, and large bore nowadays is like an 18 gauge. I don't see anybody go larger anymore. When I first started as a medic, we were doing 14 gauges in everybody, which was always fun. So those are large. Those are definitely large. That's what we consider large bore IVs. But now 18 gauge is going to be the preferred catheter we're using in everybody. And then we're, while we, usually at the trauma center, our first IV has a 20 cc syringe, and we pull 20 cc's of blood off with our initial IV, so we can run all of our labs. And we'll talk about what labs we're getting closer to the end, but we want to like type in screen or type in cross match that patient so we can figure out their blood type and give them hopefully whatever their blood type is, but if not, we get a universal donor. If we can't get a peripheral IV, we can do an interosseous IV, so we can get, like you see that drill in the top left there. That's called the EZ-IO, and we just basically drill. Usually the easiest place is going to be in their tibia, but you can also go in the humerus as well. And we'll practice that with some trainers during our lab during this block. But that bottom picture there is going to be a central line. So that's going to be, that's the ideal access we would like to get. It has a larger bore, so you can push fluid. I want to say it's like a liter of blood in under a minute with our Belmont infusers or whatever brand infuser we're using. So we usually have machines that are gonna push the blood in for you. The interosseous access, you can't push fluids as fast, so they're kind of limited. So that's, not really like what we prefer definitively, but if that's all we can get, sometimes we need to use it to push blood or medications. It just goes a lot slower, so you need to consider that. And then everything needs to be on a pressure bag, or should be on some sort of pressure bag, and that's kind of that's what you're gonna have at the rolled ones and things like that. So you'll just have, it almost looks like, a little blood pressure cuff type thing. Your bag goes in it, and then you can pump it up, and it will infuse a lot faster. The machines we use, like Belmont's the most common one, and you can run that liter in like under a minute. So that's usually what we're pushing blood in, is some sort of infuser. We can give, meds and blood intraosseous, but it just is a lot slower, so we need to factor that in if that's the only access we have in that patient. And then always remember, crystalloids are going to dilute everything and cause a coagulopathy, which is why if they've lost blood, we want to give them blood. All right, let's take a 10-minute break, be back at 11.
You said like 2 weeks ago. It's this week. Well, days. There's 12 days between.
Are you sure there's not?
I was like, let's go.
I get him in hand. I don't know, I just want it. I like it when the answer was like Carolyn Lead. I was like, oh,
Too good.
yeah, again, not like insanely far, but everyone else is. But yeah. This
No.
yeah. Likewise, this is the first one ever lost a kid who's the future PBR freaking champ.
Yeah, right.
Keep track of that kid. So she like starts rubbing on my mouth. And I'm just like trying to spit onto this thing, and she's like a 40 Terrible. Patient does not tolerate my
All right, let's keep going. So, during our circulations, when we're establishing that access, and then we're deciding whether we need to start blood or not. So we also have what we call massive transfusion, which is normally over 10 liters of fluid, or 10 units, sorry, not liters. 10 units of blood products given. Typically those patients require some sort of urgent surgical intervention, so they need to go to the operating room. But sometimes we have to stabilize them first in the trauma room prior to going anywhere. And this is different than like our emergency release blood products, which is what we're usually pulling on every trauma patient that we're worried about bleeding and we need to get blood or hemorrhagic shock with. So if we're doing our whole blood, usually we do the universal donor, which is O negative. And then, there's a lot of different methods. We may find that source of bleeding just visibly on the external exam. If we put a chest tube, we make a significant output. And then we hook them to our, what we call Pleurovac, which can tell us, which can actually quantify it with an actual number on there for milliliters. Our EFAST exam can be helpful during the primary survey, so maybe there's an intra-abdominal source of bleeding identified on there. Or we go to CT imaging after we finish our primary survey. Blunt trauma can lose quite a bit of fluid into the intra-abdominally or like pelvic. They say like 3 or 4 liters of blood loss in the pelvis, especially for like closed injuries without us knowing it. So one of the things we're assessing during our primary survey is our we're checking for pelvic fractures. So we're just applying a downward pressure onto the pelvis and checking for any instability, crepitus. And if we find that, we need to put them in some sort of pelvic wrap or sling. So we have like fancy pelvic wraps we can use that look like kind of large, they almost look like weightlifting belts that we place on there. If you don't have that, you can use a bed sheet and wrap it around the patient and tie it and pull it on each side so that you can try to help tamponade that bleeding from hitting those like fractured bone ends. And then we want to consider that traumatic coagulopathy, especially when we're dealing with hemorrhagic shock, and if we're going to give any like crystalloid fluids, which we avoid in these patients, but that traumatic coagulopathy causes that defective clotting, affects your platelet function. We try to use a 1-to-1-to-1 ratio, so that's PRBCs to FFP, so plasma and platelets. And it takes a while to unthaw those other ones, like I said. So we found that we can do like 1-to-1-to-1 is what we call balanced resuscitation, which can be difficult because we can't unthaw everything. So we found that we get a lot more in balanced resuscitation if we use fresh whole blood. And then if we remember like our lethal triad and all that, so we worry about that acidosis and hypothermia as well, and can contribute to that coagulopathy. So that's why after we expose that patient, we want to cover them back up to prevent any hypothermia. We also have what we call a Reboa. Do I have a picture on here? Yeah. I think it's in another slide, or another deck. So we also have Reboa, which, we talked a little bit about like thoracotomies, right? Like resuscitative thoracotomies. Didn't we show a video of it? Maybe not. So we also have a tool that we call Reboa, which it's fallen out of favor, it's fallen back in favor. It's on like our TC3 guidelines still. But basically we can use the Reboa, which is you can cannulate the femoral artery and you stick, basically it looks like a large central line type device, and it can go all the way up into the aorta, and then you inflate a balloon, and then you're basically tamponading or stopping all of that flow to the non-vital organs. So the goal is to keep the brain and the heart pumping. So we inflate that cuff or balloon, and then we don't get any sort of flow down to those lower extremities, and we can preserve that blood. It's a temporizing measure, but it is something that, you know, they will practice and use them in trauma rooms, but we more commonly we're trained to use them like in like deployed setting. The problem is if we keep the balloon up for more than 30 minutes, it causes like significant downstream effects and sepsis. So it's not, you know, it's kind of iffy right now on the data on whether Reboa is useful or not, but it is something you guys will be trained on. And then our TXA, so we want to give some sort of antifibrinolytic in these trauma patients. So typically we're giving them 2 grams initially to start with. You know, the studies have kind of borne it out. So if they receive it in the first 90 minutes, it's got the best, or it's the most efficacious. But within the first 3 hours, ideally is when we want to get that TXA on board in these patients. So that's something we're going to give them, you know, in the trauma room. It's something you guys have in the roll ones. Medics will carry it downrange as well in their aid bags. So it's something to be familiar with. Next, we're moving on to D, so disability. This is when we're going to check level of consciousness, GCS, what's their pupillary response, what's their reactivity, is it normal, is it sluggish. We also check, you know, their motor function with our GCS score. You know, things to consider, you know, if really in the trauma patient, we're not really assuming it's going to be like a blood sugar issue, but sometimes if they present and we don't, it's like undifferentiated, we don't know what's wrong, something we can consider is glucose and intoxicants as well. And then anybody with head trauma in the GCS less than 15, we just want to kind of assume it's a head injury until proven otherwise, so we need to manage them accordingly. And here's our GCS. So I know you guys have been tested on this before. So we're looking at, you know, what's their eye response? Are they opening their eyes spontaneously? Do they open it when they're talking? When you're talking to them, do they only open their eyes in response to pain? And then we're looking at verbal. Are they alert, oriented, the time, place, person? Is it confused speech? Are they just like babbling and inappropriate words? Are they just making sounds and then no response? And then we move on to our motor response, so they can obey commands, they can move their extremities, or they only move it to some sort of pain or localized to pain, and then flexion, withdrawal from pain, and then we got our decorticate, decerebrate posturing, and then no response at all. And we tally those up, so 8 or less, that's when we need to intubate. The lowest score you can have is 3. So you can't get a 0 on it. All right, so anybody with a brain injury, we'll talk about it during our traumatic brain injury lectures. You know, our goal is, we like to say normal or everything. So we want to keep their vital signs in the appropriate range and a little bit higher, especially for brain injury. So any hypotension or hypoxia has like a significant increase in morbidity and mortality in these patients. So our goal is to keep the systolic blood pressure above 110 if we suspect any sort of brain injury. And then we want to make them U and normal everything. So euglycemic. If we have signs of herniation, we can consider hyperventilation, but we don't do prophylactic hyperventilation, which we've always talked about. I guess it used to be a thing a long time ago in head injuries, but we don't prophylactically hyperventilate because it can lead to vasoconstriction and worsened outcomes. It's a last-ditch effort we're going to use in these patients to reduce that intracranial pressure if they're herniating. And then we can consider like long bone immobilization in these as well, so we can use our traction splints and things like that. And then trauma naked. So everybody, if they're not exposed at this point in the trauma room, we're doing it all usually at the same time. So first thing we're doing, cutting everything off while we're assessing the ABCs. But if we haven't at this point, we need to completely expose that patient. So we're taking everything off. That's why we say trauma naked. And then we want to make sure we evaluate the posterior portion of that patient as well. And that's usually the thorax, because you can lift up the extremities normally, as long as they don't have like significant fractures or anything. If they do, you might want to wait till we log roll that patient. We need to look in all those other areas, like in the axilla, we need to evaluate like the posterior neck as well. So we need to make sure we look at that C-spine, and then we palpate, from the C-spine all the way down to the L-spine. And then we're checking for any gross rectal bleeding, and we're checking a rectal tone at this point as well. All right, we want to look at that perineum. So is there any bruising there, bleeding, lacerations? And then after we finish this, we want to cover the patient to prevent hypothermia. So sometimes we'll just use blankets, but a lot of times in a trauma room, we use what we call a bear hugger, which is, it almost looks like one of those air mattress floaties in a pool, and it blows hot air into it, and that'll help warm the patient. And we put a blanket over that. So usually bear hugger is a brand name that most places use. And we're just trying to prevent that like lethal triad on there. So we're gonna attempt to prevent that hypothermia. And then we do our FAST exam at this point as well, if we haven't done it already. Technically, if you're going in the sequential fashion of A, B, C, D, F, G, this is when we would do it. Normally at the trauma center, one person's designated to get the FAST exam, and they kind of just, while they're doing the ABCs, they kind of, slide their arm in there so it's out of the way and they get a FAST exam. But, what we're looking at is for any like intra-abdominal or intrathoracic bleeding. So we're looking at the right upper quadrant, left upper quadrant. We're looking for any sort of like suprapubic or pelvic bleeding that we can see. We're also assessing the heart, so we're looking for any like tamponade. And then we can look at the lungs as well. That's what the EFAST is. So like it's the enhanced focused assessment sonography for trauma. So we can look at lung sliding as well. It'll make more sense in block 5 when we're actually performing these on each other and learning how to do that. But as you can see here, this is going to be our right upper quadrant view. So we're looking at the liver, or what we call Morrison's pouch. So we're looking for that blood where the arrow is on there. So you'll get that stripe of blood in there, and that's a positive FAST. And that's usually the first place that blood will pool, or the dependent area that will first see that intra-abdominal bleeding in. So we can help identify where that source is, and then if they're stable, they can go to the CT scanner. But like we always say, in the ER, the CT scanner is where they go to die. So if it's up to us, we say, hey, take them to the operating room, but it is helpful for surgical planning if they get a CT first, so there'll sometimes be a little argument going on with all of us, but it's nothing you guys need to be aware about. And then some of the other interventions we give, especially with penetrating injury, we're going to give them like a tetanus shot during all this as well. All right, we'll cover some of the injuries of importance that we like to identify during our primary survey. So severe head and spinal injuries, that's why we're doing, our GCS on these patients. We're checking their pupillary response. We're checking whether the pupils are equal. So, do I have a blown pupil? Am I concerned for some sort of herniation at this point? We also want to, if they're able to, we'd like to have them moving all of their extremities to do just a quick neuro exam for any like spine trauma. And then, C-collar, We already kind of talked about, we remove it during intubation. What is this called?
Battle signs recognized.
Yeah, battle signs and raccoon eyes, so. And what is this a sign of? Yeah, basilar skull fracture, so these can be indicators on your physical exam that they have some sort of head injury or if you see these signs of a basilar skull fracture. Other things we want to identify, like a tension pneumothorax or a hemo pneumothorax. So, do I need to do a chest tube? And this is going to be one of the more common interventions we're going to be performing, especially for blunt and penetrating trauma. So, any tension physiology, we're doing our needle D, and then followed by followed by chest tube or tube thoracostomy. We can also identify it with our EFAST. We get a chest X-ray as well, but once again, we don't need the EFAST or a chest X-ray. Pneumothorax is a clinical diagnosis, so if we suspect it, we're going to be putting chest tubes in that patient or a chest tube in that patient. Sometimes bilateral chest tubes in the patient, depending on the trauma. Next is our tamponade, so that's one of the other pathologies we're evaluating for when they come in. And we can see, we can help with getting our EFAST exam so we can see that fluid around the heart. It can also, we can also, assume there's kind of an injury because if they have a penetrating stab wound, anywhere near the heart, we want to be concerned for developing a cardiac tamponade. So we get all that blood accumulation, your heart can't pump appropriately, and we start to see decrease in those filling pressures, and then it manifests in that shock type picture, or what we call Beck's triad. And then a small amount can have an effect on the patient because it's not a very large area for that fluid to go. So even like 100 milliliters can start to lead to symptoms in that patient, which we can identify smaller amounts with our EFAST exam, which is important. And then Beck's triad is at muffled heart sounds, hypotension, and distended neck veins. Other indicators like narrowing pulse pressure. It says elevated CVP. We're not really getting central venous pressure, but we're just kind of estimating it on there. But if we see any of those, we need to assume it's cardiac tamponade. We have to do something about that. Here's a tamponade on our EFAST exam. So you can see that fluid around the heart. It's affecting the ability of the ventricles to pump. So pretty significant on there. This patient's likely going to need some sort of, either a pericardiocentesis or a more definitive measure in the operating room. So if the patient is stable enough, temporizing measures can be in the emergency department, pericardiocentesis. We prefer them to go to the OR. Sometimes we may do a thoracotomy in those patients, so we open the chest up and we will fix it that way prior to going to the operating room if they're unstable or we have loss of signs of life. But prior to that, we're getting blood products on board or some sort of fluids prior to any of those interventions. All right. So here's our ED thoracotomy guidelines. You'll talk about it more in surgery during the trauma lecture, but really, any unstable patient that we don't think can survive transfer to OR, we're going to perform a thoracotomy on. And then also patients who are in cardiac arrest, but they had demonstrated signs of life. And then patients we don't usually do it in, anybody that's pulseless or, no signs of life in the field. If asystoles are presenting in rhythm and we don't see anything on our H's and T's, we can fix. Most patients may not get a thoracotomy. Any prolonged pulselessness, so over 15 minutes. There's different criteria you guys talk about in surgery, but we don't really get too much into it during our lectures. And then one of the things with a thoracotomy, you have to have a surgeon there if you're going to do a thoracotomy because they need to go straight to the operating room since you're opening up the chest, which hopefully makes sense. It's not something you're going to do at your roll one prior to a transfer of that patient if you don't have a surgeon immediately available. And here's what it looks like. It's pretty pretty significant procedure. So you can see they basically go from the bed and they open it all the way up to the sternum and they expose the heart. And they also cross clamp the aorta so that we can keep all of that blood to those vital organs there. That's poor form if you got your watch on when you're doing thoracotomy, by the way. Yeah. They got yelled at for sure. But when we're doing traumas, like all of us, we take our rings off, we take our watches off. We don't want anything that can potentially cause any infection or get lost. You know, it would be very bad. I mean, you should have gloves on, but still. Here's another great ultrasound of our tamponade, so you can see the heart is barely pumping there because that fluid is compressing it. Then we have our traumatic cardiac arrest. So most of these patients, you know, if EMS has any suspicion that there are signs of life, or if they think, you know, CPR is going to benefit this patient, they're going to start it. Once it's started, you know, when they present to the ED, we have to make a decision whether we think this is going to be futile, like is this patient going to survive or not? And we kind of base that on EMS. Did you witness any signs of life? Was there ever a pulse? Did you ever have a rhythm on your monitor? And then if they did have any of those, and a lot of times we'll do an emergent thoracotomy or resuscitative thoracotomy is another name we call it. But really we want, you know, the best outcome or strongest recommendation for thoracotomies. You know, anybody with penetrating trauma witness signs of life during transport. And at least some sort of cardiac activity is going to be our best case scenario. A lot of patients, since we don't know how long they've been out, we only know like the EMS transport time. We do a lot of thoracotomies, especially at level 1 trauma centers. Just that there's a chance we can save them, we can. So you know, we go by these guidelines, but you know, they're kind of a rough guideline in clinical practice. But you guys aren't making that decision anyway. That's the surgeon. Other things we need to worry about: penetrating abdominal trauma. You know, almost all of those are going to get an exploratory laparotomy, so they're going to have to go to surgery. They're going to open their belly up. They're going to have to find where that bleeding is and then stop it. So anybody that we suspect this in the trauma room, they need to go to the operating room for an X-lab. So we're not usually CT scanning them. We're transporting them immediately to the OR. Imaging isn't really going to change anything. We know they're going to have to get opened up, so that's why most of these patients are going straight to the operating room. You know, sometimes if they're stable, we may place like an NG tube and decompress the belly, decompress the bladder with catheters, but those don't need to delay operative intervention. So we're not doing it if they're going straight to the OR. We're not going to wait on any of those. Let's move into our secondary survey. So we only move on to this once we've completed the primary survey. We've gone through all our ABCs. We've fixed any life-threatening injuries we found. So if they need an airway, we've intubated them. If they need a chest tube, we've done that. If they need blood, we've already started blood products. If the patient is then stable after our interventions, we can move on to the secondary survey. And secondary survey is just a rapid head-to-toe examination. So we're trying to identify any additional injuries that might need some sort of treatment. So we're checking for smaller bone fractures at this point. You know, we're palpating everywhere on the body. If we do a better neuro exam, we will perform one at this point. But once again, if there's any question of stability, the patient needs to go to the operating room. If they're stable, then CT is going to be probably our best option at this point to identify any of those injuries. But here's kind of a recap of some of the potential causes of instability. So scalp lacerations have a tendency to bleed a lot. So at this point, you know, in our secondary survey, we can fix that by just usually placing some sort of suture on there and occluding that vessel so that we can stop that bleeding. Sometimes they bleed. I mean, I've had them shooting across the room, so sometimes we'll get another person and just throw a suture in there during our primary survey, but that's not how we test. At this point, looking for any facial instability or anything that could cause airway compromise if we haven't identified it already. We want to check for hemotympanum, so looking for any of those basilar skull fracture signs. So do I see any blood behind the tympanic membrane? And then we can look for like, septal hematomas, especially if they have some sort of nasal fracture, we want to evaluate for that. And then like avulsed teeth or jaw instability, we need to consider that because if we haven't taken their airway already, we probably need to. Then we can also look more thoroughly at any other penetrating injuries. Maybe once in a blue moon, there might be a tangential gunshot wound that doesn't penetrate the intra-abdominal cavity, but most are considered to be penetrating the cavity and are going to the operating room, but rarely you might see something there. Hasn't penetrated that peritoneum yet. Then we also want to look for like the urethral meatus. So do I have any, like urologic emergencies that might need to be treated at this point? And then we've already, assessed our peripheral pulse and everything. But all right. So first, looking at those scalp lacerations. So here are some tools we can use to help occlude those. Like there's clips that you can use on there. Sometimes you can use staples. A lot of times, we just throw a suture over that vessel if we can identify it and stop that bleeding initially. If you see that hemotympanum, you need to suspect some sort of head injury or basilar skull fracture. We basically repeat all of our exam from our primary survey during our secondary survey. So we're checking the pupils again, especially if they have head injury. Do I see any changes in their pupil area of response? And then we're going to look for other injuries in the neck and thorax. That might be a little bit more minor or we overlooked on our initial primary survey. And then, if we suspect that facial trauma, basilar skull fracture, we want to avoid that NG tube because you don't want to put it into the brain, which can happen. So they might do like an orogastric tube at this point to decompress the stomach. And then we want to check that urinary or the urethral meatus. So do I see any blood there? If I have blood there, then we want to do a retrograde urethrogram prior to any Foley catheter in that patient. So that's always something we want to identify early. And then we always talk about the prostate or high-riding prostate. I've never identified one during my trauma exam, but I guess it's something we always want to consider. All right. So, if we have any like vaginal trauma or bleeding, then we need to perform some sort of manual and speculum exam to identify where that laceration is. And they may need to receive some sort of suturing at this point. So we'll look at that during the secondary survey. We're also checking the rest of the extremities. So the secondary survey can help us identify like whether I need, plain film x-rays on really like sometimes it's all four of their extremities, depending on what type of trauma patient's mechanism of injury. And then we're also, serially assessing GCS during all of this and motor function, sensory function. And some things aren't going to manifest yet during our secondary survey. So a lot of orthopedic injuries can be missed. And we'll identify them during a tertiary survey, which sometimes doesn't happen for 24 hours after admission. So a lot of times for like our trauma, you guys will get an ICU rotation probably. So a lot of times they'll go straight from the trauma room to the operating room to fix whatever life-threatening injury they have, whether it's an exploratory laparotomy because they have some sort of intra-abdominal hemorrhage, and then they'll get to the trauma ICU. And at that point, so we do the tertiary exam, and that's when we might find some of these other fractures in these patients or other injuries. So sometimes a thorough exam isn't performed until 8 to 24 hours afterwards, once they're stabilized after the surgery. All right. So here's our recap. Primary survey, that's our X, A, B, C, D, E, F, G. Address those life threats. We need to perform some sort of intervention for them if we find them during our primary survey prior to moving to the next portion or to the next whatever sequential letter is. We have to deal with that first. And then our secondary is going to be, a head-to-toe exam, history if they're you're able to elicit that from the patient, and they're alert and oriented. And then the tertiary is usually after they're admitted to the hospital or come out of the operating room and they're on the ICU at that point. So some of the imaging and lab tests, so adjuncts to the primary survey are going to be our chest x-ray and pelvic x-ray, and then our EFAST exam will be the only imaging that gets performed during the primary survey. And then anything else will have to be done after stabilization, so whether it's CT at that point versus plain films, once we identify in the secondary survey the patient's stable. EFAST, great tool, to identify any intra-abdominal bleeding, pneumothorax, hemothorax, tamponade. Those are, considerations we think about with the EFAST and we evaluate for. We'll train on that in Block 5. And then once again, only stable patients to the CT scanner. Plain films can be done after we've completed our primary survey. For our imaging, most patients, especially in like the, depending on the mechanism, but most patients that go to especially a level 1 trauma center, if we stabilize them, they're all going to get basically a head to toe CT. So they get, head, brain, face, C-spine, and then chest, abdomen, and pelvis with contrast. And then we can reconstruct like the T and L spines with our imaging to identify any of those other concomitant injuries or injuries we weren't able to see on our primary survey. And then what labs are we getting on these patients? So most trauma patients, we do a standard set of labs. So you're getting your blood type and screen. We're looking at coags. We want to get our CBC. We look at our H&H, so hemoglobin and hematocrit. We'll get venous blood gas or an arterial blood gas on them. We get the CMP. We do a UA on these patients. Not every patient gets an ethanol, but most will, especially if we suspect any intoxication. They'll get a drug screen added on there as well. We get a pregnancy test in all childbearing age females. And we have like what we call an iStat machine, which we can run point of care blood tests, especially our VBGs, and we can get our H&H and everything in the trauma bay on these patients to help expedite our care. And then, if we, have an ultramental status, we don't think it's a head injury, we want to look at, blood glucose, so we do a D-stick on these patients, especially anybody with a history of diabetes. We normally get a troponin on all these patients, but if you haven't, we consider it, especially as they age. So over 55, consider engaging troponin. And then this is our most important part. What's the disposition of these patients? Are they coming or going? So most trauma patients are going to be admitted to the hospital for at a minimum repeat serial examinations. Anybody that is unstable or we suspect any sort of surgical pathology, they're going to go to the operating room. And if we're not at a trauma center, level 1 trauma center, or we don't have neurosurgical capabilities or spine surgeons, those patients are going to need to be transferred to some sort of trauma center that has that capability. And that's for a lot of like the rural hospitals and places that can't, we can't transport them initially to the level 1. So, in more of those remote areas, we'll have to stabilize these patients prior to any transfer. And then, we need to assess all of our labs that we ordered. So we want to, look, identify any issues we have with those and whether it's going to change our management. We have to deal with that at this point. And then, like I said, if there's, no clear indication for surgery, then we need to do serial exams within the hospital. Sometimes we will discharge patients if everything came back normal. The patient's maintained appropriately, vital signs are stable. We didn't identify any injuries during our primary, secondary, and tertiary survey. CTs are normal. Those are patients we can consider possibly sending home, but we usually admit those patients if they had the appropriate mechanism, especially if they went to a level 1 trauma center. And then here it is, admission versus observations, typically what we're doing for these patients. You know, some may be admitted for serial neurologic exams if we have a head injury or, you know, our GCS is decreased or CT doesn't show anything. So those patients, a lot of times we admitted just for serial repeat neuro exams. We also want to consider like, you know, any delayed pneumothorax or pulmonary contusions are pretty common. So the right, you know, the appropriate mechanism we're admitting most of those patients and serially evaluating them or daily chest x-rays. And then hollow, like viscous injuries or organ injuries, a lot of times don't manifest on our initial imaging. So if we have any suspicion of it, we admit those patients for serial observation. And that's like your pancreas and some of your like the duodenal injuries can sometimes hide and they may not manifest initially. All right, what questions y'all got? I know it was a lot, man. Nothing. Anybody got questions on their presentation tomorrow? No? She'll be fine, you guys all be alright. I haven't failed anybody yet, so